Hello, everyone. This is your host, Mehak Shan. Welcome to a new episode of the Heart Success Podcast, where we discuss practical knowledge and the latest in the field of cardiovascular medicine. All listeners be advised that the podcast is for personal information, education, and entertainment only. Information from this podcast should not be used as medical dictum, and all decisions related to patient care should be made in consultation with care providers.
Today's episode complements our previous episode on fluid restriction. In this episode, we're really going to focus our attention to salt restriction in heart failure patients. I would certainly suggest that you listen to our previous episode on fluid restriction for a more complete understanding, since both these episodes do go hand in hand. Dietary sodium restriction is arguably the most frequent self-care behavior recommended to patients with heart failure and is endorsed by all heart failure guidelines. However, the data on which this is recommended is really drawn from modest, small-scale studies and really few randomized control trials in this arena. These studies also have produced somewhat inconsistent results. For the purpose of discussion today, I just want to standardize the way we talk about sodium and salt restriction. When you say sodium restriction, it goes hand in hand with salt restriction, but I do want to make sure you understand the difference. Salt contains both sodium and chloride. So when you say salt, usually sodium forms part of it. For example, 6 grams of salt actually contains 2.3 to 2.4 grams of sodium. If you're thinking about this, really 40% of salt is sodium. When you recommend a 3-gram salt restriction, for example, what you're really recommending is sodium restriction, which is 40% off of that 3 grams, really 1.2 grams. So when you're advising your patients, I want to make sure you use the right terminology. It's a little bit easier to just talk about sodium restriction and measure sodium, because that's what most of the labels to present, the food labels. Sodium, actually, we can talk in milligrams or grams for the purpose of this discussion today. Some studies will present sodium in the form of milliequivalents or millimoles. 1 millimole is the same as 1 MEQ, and 100 MEQ or 100 millimoles of sodium equals 2.3 grams of sodium. So that's the conversion. The average American consumes 3.4 to 3.7 grams of sodium daily. That's close to 9.5 grams of salt daily, just so you get that correlation. Now, coming back to really the evidence and why this conversation is so important today is because there is controversy even in your guidelines when it comes to recommendations for salt or sodium restriction. The American College of Cardiology Foundation and AHA guidelines for the management of heart failure in 2009 gave sodium restriction in patients with symptomatic heart failure a class 1 recommendation to reduce congestive symptoms. They did say that this was really based on a level of evidence C equivalent to expert consensus. More recently, the 2013 ACC-AHA guidelines downgraded the recommendation for sodium restriction to class 2A. The level of evidence, however, remained C, which is really poor quality data, expert consensus. Recommendations actually were provided on the basis of stage for heart failure, where they said a 1,500 milligrams per day of sodium intake or 1.5 grams per day of sodium intake should be considered appropriate for stages A and B heart failure in order to prevent heart failure development. For stages C and D heart failure, which is really the clinical heart failure, a sodium intake of less than 3 grams per day was suggested for symptom improvement. On the other hand, the European Society of Cardiology guidelines took a different approach. They recommended avoiding excess salt intake, which was really more than 2.4 grams of sodium per day. They did not present a level of evidence for this recommendation. And really illustrating the paucity of data in this arena, you can look at the American Heart Association's Presidential Advisory Panel, which recommends that sodium should be restricted to really 1.5 grams for most Americans. It's actually a little bit lower than what the guidelines recommend for even heart failure. So it really highlights the variation in recommendation from different panels and different committees. So we have a guest today with us, Dr. Scott Hummel.
Dr. Hummel is really a superstar in the field of heart failure. We are very glad he's able to lend his expertise today on this very complicated and controversial topic on sodium restriction and heart failure. Dr. Hummel works up at the University of Michigan.
He's currently an associate professor of medicine and cardiovascular medicine,
the medical director for the heart failure program, and the section chief for cardiology
at Ann Arbor VA Health System. His training, medical school, was at Columbia University College of Physicians and Surgeons. He stayed on to complete his residency at New York Presbyterian Medical Center, Columbia in New York. Finished his fellowship in cardiology at the University of Michigan Health System and is currently board certified in advanced heart failure and transplant cardiology. Dr. Hummel's own research has been funded by multiple agencies, NIA, NHLBI, AHRQ. His work focuses on evaluating dietary patterns, the role for inflammation and oxidative stress pathways among patients with cardiovascular disorders, especially heart failure and heart failure with preserved ejection fraction. His work aims to understand the impact of diet on HFpEF development and progression to facilitate healthy eating through technological innovation. Welcome to Heart Success, Dr. Hummel.
Thank you very much for the kind introduction and for the opportunity to speak about what I think is an important topic, although a controversial one.
Yes. Dr. Hummel, before we start and really go into some discussions on salt restriction, could you tell us a little bit about you for our listeners?
Sure. Well, from a professional and academic standpoint, one of the reasons I got into this area of research was that one of the first patients I saw as a cardiology fellow was intubated in her own living room after eating Thanksgiving dinner. And it was such a dramatic experience in her life. And, thinking about how that typically salty meal might have contributed to that decompensation and kind of looking into the literature in this area, specifically as it relates to heart failure with preserved EF, it looked like salt and vascular response to salt might actually be a really important aspect of the pathophysiology. And so that's kind of how I got into doing what I do. I think every research project, at least for me as a clinical researcher, stems from something I saw as a clinician. So that's kind of how I work through those things. From a personal level, just got finished helping coach my two daughters' softball teams and enjoying summer in Michigan.
And, the other thing I actually wanted to bring up today was I've been getting active on Twitter and social media, more so in the last 3 months. I've been really witnessing the massive amount of information exchange that occurs on Twitter, especially within cardiology and among cardiologists. What are your thoughts about the emergence of social media into our conversation today?
That's a controversial issue too. I think your point is very well taken. There's a lot of discourse on Twitter. I think from my perspective, I view it as a positive. I am more of a liker and a lurker, I guess, than a tweeter. But I do try to tweet out, papers I find interesting or things about some of our own work. But I think the value of it, for me, is often in areas of cardiology that I'm not quite as well versed in or not working actively within. You might see very erudite and extensive discussion between interventional cardiologists about a particular case, or about electrophysiologists about how to treat a certain rhythm that I haven't thought about in that way. You might have a statistician who you've used their methods in your own research, commenting on the methods in a really important paper and giving some additional insight that you might not get elsewhere. So in that sense, it's kind of like this, democratizing way of getting advice and input from people you might not otherwise meet. But it's like anything else, you really have to be, take some things with not to make a bad pun with the topic today, but with a grain of salt. You have to evaluate things critically, and not everything you see on Twitter is true or correct or necessarily aligned with what you think, and using it in that way.
Yeah, no, I've certainly found it very useful more recently. For example, I think the data or the early results for Paragon heart failure were revealed by Novartis yesterday, and it was all over Twitter, and that's really how I found out. It's sort of the early data was negative, but it's interesting how information really comes to the front through Twitter now, especially even in the medical field for us.
Yeah, although I was a site PI for that trial, and really there were so much speculation and people kind of running away with the one line that just said it didn't meet its statistical primary endpoint. There's going to be, I hope anyway, a lot more nuance to that trial and a lot of insight gained from it, even though it wasn't, quote, technically positive. I think it's a little too early to make too many conclusions about that.
It's exactly what you said. It's just going to be speculation for another month. For our listeners, Paragon heart failure was really the study that looked at sacubitril valsartan and its role in patients with heart failure and preserved ejection fraction. As you may know, we already have data from Paradigm heart failure that was really, really positive and sort of changing the field of medical therapy in heart failure, reduced ejection fraction, probably, I think, 3 or 4 years ago. Going back to our topic of conversation today, the role for restricting sodium in the diet from a heart failure standpoint. Dr. Hummel, I don't know if you had a chance to listen to our previous episode where we tackled fluid restriction and we tackled quality of data and what we really knew in terms of the evidence. What is your practice with respect to fluid restriction and your stable and quote-unquote decompensated, unstable heart failure patients?
Yeah, so I did listen to that last episode, and it was quite a helpful outline of the data that are there and the limitations and challenges of them. Fluid restriction is a tough one because I think people are just kind of wired to drink a certain amount, and I am a little less prescriptive about that maybe than some other things in heart failure management. I feel like the main times when I get a little bit more intensive about fluid restriction or when people have pretty substantial hyponatremia. I think that's a setting in which fluid restriction can be quite helpful. But I think the amount of fluid that people ought to drink may depend on the situation. If you're out on a hot day and sweating a lot, you probably ought to drink a little more that day. And if you're just kind of going about your business and in your house, then maybe less on that day. I typically give a standard 2-liter fluid restriction, but again, I'm not quite as strict about that, if you will.
That's great advice. Sodium intake really is quite high for the average American. I think I read from your papers even quoting that the average intake is 3.4 to 3.7 grams per day, but there is a wide variation where we have people taking up to 6-7 grams per day. When we talk about salt restriction, or maybe we should call it sodium restriction, how do you define sodium restriction in your practice? Is it disease specific? And do you have a cutoff where you draw the line?
Yeah, so that's a great question. Even in our own patients, who have presumably received lots of education along the way about restricting sodium, at least when we've measured it in our group, it's not a whole lot lower than that 3-point-something grams per day threshold that you mentioned. I think everybody would say that 2 grams per day is restricted. As you know, I'm sure the American Heart Association has recommended a lower threshold than that, really for most populations at this point of 1.5 grams per day. But in a sense, not to be, it's kind of a patient-specific thing. I mean, if you have a person who's eating gigantic amounts of salt all the time, then restriction for that person might be 4 grams a day. And I think a lot of what I try to do in clinical practice is meet people where they are. And if people have been eating a certain way their whole life, then, telling them to get down to 1,500 milligrams a day of sodium is going to be really hard for that person, and you really just have to, it's a process, I guess I tell patients, and not everybody's going to end up in the same spot. As far as disease specific, my clinical practice is primarily within heart failure. And so, I think that's really the thresholds that I'm talking about. Although I guess as you know, there are suggested thresholds for people with hypertension at risk of heart failure. I'm sure we'll talk about that later.
Yeah, now is actually a great time to touch base on the hypertension guidelines, the multi-society hypertension guidelines, which also had the ACC-AHA from 2017. in their guidelines, they talk about salt sensitivity and worse prognosis among certain populations that are more salt sensitive. And they also recommend some degree of sodium restriction in the overall population. Could you maybe allude to that a little bit?
Yeah, so I think you bring up a very, very important point, albeit one that maybe we don't know enough about yet, which is that the answer may not be the same for every patient with heart failure or indeed at risk of heart failure. I think I mentioned that story about looking into the literature after I had that patient with that terrible event after eating Thanksgiving dinner. And, a lot of the animal models, or at least proposed animal models of heart failure preserve the F, are these models of salt-sensitive hypertension, where you give the animal a salty diet and they develop something that looks like HFpEF. And if you don't give the animal too much salt, they have relatively minor problems. And there are a number of studies out there suggesting that humans may have sort of similar physiology in some ways, and a lot of risk factors for heart failure, like obesity and diabetes and chronic kidney disease and hypertension itself. You may tend to have more of a blood pressure response to sodium intake than someone without those risk factors. So it kind of goes along with the idea that this might be an important thing in heart failure progression and development. But one of the challenges with salt sensitivity is there isn't really a gold standard for how to measure it. And it's not, I think, as you may know, it's the proposed methods are not really very clinically applicable. So Part of what we're doing in some of our research at the VA and at the University of Michigan is actually studying what we think may be a biomarker of the adverse response to sodium. It's something you could get at the bedside, hopefully to tell you whether somebody's at risk or not. I'm sure if I'm answering your question, but
no, that's great. No, absolutely. And that's why we're here having this conversation today, because I want to make sure we have an expert really comment on this very complex conversation that comes out of salt restriction and sodium restriction in heart failure, something we take for granted and really widely recommend for all our patients with heart failure. When I am evaluating patients with heart failure in the outpatient or even the inpatient setting, some of these patients are getting readmitted pretty often as well, I have a spiel where I talk to them about watching their sodium intake, what foods to watch out for, the breads, the cheeses, reading labels. I'm not sure how much of it really they practice in their day-to-day life, but what is your approach when you talk to these patients when it comes to really dietary counseling and counseling regarding sodium intake?
Yeah, I guess the first thing I would say is I don't feel like I have nearly enough time to give it the attention it deserves in a standard clinic visit, or indeed when you're seeing patients on the inpatient wards. This is a complex. I mean, what people eat is an incredibly complicated topic and obviously different for every person. And so I think, again, meeting people where they are. Some people are very, very knowledgeable and already reading labels, and they understand what that information means and what a serving size is and all these things. And other people, you may just be focusing on broad categories. And so if someone is going out to eat fast food every day, let's say, you're like, okay, why don't we try to cut that down to 3 times a week? Or if someone's eating canned vegetables rather than fresh or frozen, you might try to get them to switch how they're doing that. Trying to in a short period of time figure out what are the major sources of salt or sodium intake for that patient, and trying to see if you can change those over time. Again, I feel like it's a process for most patients.
Yeah. And as we know, sodium is actually very important in our body. I mean, it helps maintain your extracellular volume and your intravascular volume. It regulates neurological function, nerve impulses, muscle contraction. So we really do need sodium in our body. But how does this whole conversation about salt really being bad in patients with heart failure come about? Is there a pathophysiology as to why maybe salt is bad for patients with heart failure?
Yeah, I mean, I think in the broadest sense, we know that patients with heart failure are vulnerable to retaining fluid volume, and that's often what leads to symptoms that cause suffering, like edema or certainly pulmonary edema and shortness of breath and things of that nature. And when people are hospitalized for heart failure, often they have these types of symptoms. And so I think it's kind of perhaps a natural line to draw from, you're eating sodium, your kidneys retain that sodium along with fluids, so you have the proper electrolyte balance in your body, and then that volume leads to problems. The other side of the coin perhaps might be that your kidneys And, other, as you pointed out, neurohumoral systems in your body evolved to retain sodium and fluid when you have hypovolemia, a low circulating volume. And, maybe that's part of what's going on in heart failure with reduced EF anyway, low cardiac output. Your body thinks it's hypovolemic. Neurohumoral markers get increased. And as we all know, the goal-directed medical therapy for HFrEF involves blocking all these pathways. Maybe if you restrict sodium too much, you increase norepinephrine and epinephrine and aldosterone and angiotensin and all these things which we know contribute to harm in these patients. So there's probably a balance to strike. So I guess that's kind of the two sides of the equation. If you eat too much sodium, you may retain fluid and have symptoms. I'm interested also in the idea that too much sodium may contribute to vascular inflammation and oxidative stress that may kind of worsen the pathophysiology in some patients. But then the other side of the coin is you may be, if you restrict too much, causing your own problems there.
Yeah.
There's a nice article, 2012 in Circulation, which kind of is a general outline. There's a nice figure that looks at kind of the two different sides of this equation, which I would refer the listeners to.
I actually did read that article, and like you said, they really give out a beautiful figure representation of what's really going on at multiple levels, like you said, neurohormonal levels, kidney levels, central levels, that really contributes to this phenomenon in patients. That one of the other things I wanted to discuss is that we go around making these recommendations for sodium restriction. What does the data say that patients do comply with the recommendations that we provide?
Well, I think that the data suggests that really hard to do. And I guess as a corollary to that, it's probably worth mentioning, at least from my perspective, that, most people with heart failure are older adults, average age of hospitalized patients, certainly up in the 70s or even older in some places. And, it's worth pointing out, I think, that sodium and calorie intake correlate pretty closely in the U.S. So I have become quite interested in the topic of malnutrition and heart failure. Malnutrition is a terrible prognostic factor for heart failure patients, especially those that are hospitalized. And I do sometimes worry that, people that are eating less than 2,000 milligrams of sodium might just not be eating enough more generally. And I think that giving blanket advice to restrict sodium, knowing it's complicated, knowing it means reading labels and understanding serving sizes and adding it all up and writing it down and keeping a diary, whatever you need to do, is complicated. Some people just eat less, and I don't think that's necessarily a good thing either. I don't mean to get too far off track from your original question, but I feel like we can't give sodium advice and only sodium advice. We have to make sure that people are maintaining their overall nutrition, and I think that's where having a dietitian's involvement in the patient's care is really very helpful and important, because, again, we often don't have as much time as we need to do that in our average clinic appointment.
That's true. And these dietitians that you use in your practice, are they usually trained in heart failure training?
Well, I think most general dietitians have at least some familiarity with common recommendations for heart failure. We're fortunate at University of Michigan to have a cardiovascular dietitian who has heart failure as one of her specific interests. And, she's right down the hall from where my office is. So I'm often able to have people see her the same day as they come to see me, which is quite convenient and helpful. And if she's seen them before my appointment, I can kind of reinforce some of the topics that she's talked about. I think that's really very beneficial. A lot of the patients that come to see me come from a decent distance away. And so oftentimes it's kind of continuing that discussion with a dietitian locally, is often quite helpful too. Some people are reluctant. It's obviously another appointment they have to attend and lots of things to do after that appointment, that are challenging, but I still find it helpful.
I agree with you on what you said. It's really not just sodium. You have to take a more complete approach to the nutrition for the heart failure patient. With that, I think we probably should go into some of the data that we have for salt restriction and against salt restriction in patients with heart failure. Try to reconcile these data and sort of come up with a conclusion for our listeners. If we were to talk about why this argument is being made for sodium restriction in heart failure, what data would you say agrees with that?
So I guess it's probably worth pointing out that one of the biggest risk factors for heart failure development is hypertension. And so I think a lot of the original discussion about this stems from that risk factor and some of the studies, like the TOPE studies, trials of hypertension prevention and I guess even the DASH diet studies, there was the DASH diet where there were different sodium restriction arms. Those two studies, I think, have demonstrated that at least in some patients, the amount of sodium that you eat can affect your blood pressure in a favorable way, reducing your systemic blood pressure. And so the idea that salt restriction might help prevent the development of heart failure is certainly out there. In terms of studies that have been done actually in patients with heart failure, that's where it gets really complicated. There is a series of studies from an Italian group of investigators, which I think you actually touched on in your last episode, as it was related to fluid restriction. Is that correct?
Yes.
Yeah. So the other sort of portion of those studies was looking at hypertonic saline, which is a whole other issue, but additionally looking at various levels of sodium restriction. And this is most of the randomized data that we have and most of the data that shows up in various meta-analyses of these topics. But I think it's important to point out that in those studies, dietary sodium restriction in patients that were recently hospitalized was harmful. So, people had an increased risk of rehospitalization, worsening kidney function, and actually a higher risk of death in some of the studies. And so it just really outlines what the controversy is. I think there were some important limitations of those studies, which I can touch on if it's appropriate now.
Sure.
In terms of interpreting those, the studies were done in patients with reduced ejection fraction. They were done with the patients were on quite high doses of loop diuretics, and additionally, in a number of the studies, the number of patients that were taking a beta blocker was quite a bit lower than contemporary practice. And so I think the other side of that coin, where you worry about increase in neurohormonal activity and so on with very high doses of diuretics, and then also not blocking that with a beta blocker, I think could explain, some of the adverse events in those studies, I should say.
Yep.
So I think those studies are just really difficult to interpret. I'm hopeful anyway that, and this is in stable patients, but there's a Canadian group that's leading a study called Sodium, and they published some pilot data, I think it was a year or two ago, in the first 40 patients or thereabouts. But they're using dietitians to give advice to patients about restricting sodium, and then looking at long-term outcomes in these patients, quite a large group of patients. It's eventually going to be 1,000 patients. And I hope that'll provide some insight into at least what we should do with stable patients.
One of the other studies that would really be worth mentioning here is your own study that you published last year in 2018, the Gourmet heart failure study. Maybe we could put that in this bucket of studies that really made maybe an argument for sodium restriction in certain populations. Could you tell us a little bit about your study?
Yeah, I'm happy to. So part of that stems from just in clinical care, recognizing that patients with heart failure, particularly after they leave the hospital, just have a lot of challenges in eating healthy. And, there's logistical challenges, there's educational aspects of it. There's just so many different things that patients were having a difficult time with. And we talked about the malnutrition issue as well. And so we decided to do a pilot study where we took patients at hospital discharge and randomized them to getting home delivered meals for 4 weeks versus usual care. And the meals were designed in collaboration with a commercial vendor this is what they do, is deliver food around the country, to adhere to the DASH diet specifications, and also having sodium restriction as part of this particular diet. It was a small pilot study, but quite thought-provoking for us anyway, in that we saw some pretty favorable trends towards improvement in heart failure symptoms and physical limitations, something called the Kansas City Cardiomyopathy Clinical Summary Score. And additionally, again, not reaching statistical significance, but a favorable trend towards fewer days being rehospitalized in the group that was receiving meals. And so we're hoping to parlay that into a much larger trial at many other sites to really determine whether helping people with nutritional support, part of that being low sodium after hospital discharge, can reduce readmission burden. That would be a huge shift in the way that we view heart failure care. I think it's worth pointing out that a lot of the readmissions in our heart failure patients are not due to heart failure per se, and it's possible that improved nutrition might help reduce some of those non-heart failure related events as well.
And your study really dealt relatively older population, which was really more higher risk patients.
Yeah, and again, it's kind of maybe this is a theme, I guess, of what we've been talking about, but it may not be the same answer for every patient, and so I do think that whatever blanket advice that we all, if we can end up agreeing on whatever that is at some point, it may have to be adapted depending on your patient. Just like you wouldn't give every single patient the same exact dose of carvedilol or Entresto, depending on what their blood pressure is or the kidney function, these kind of things. I mean, I think the dietary aspects of it may be similar in that way.
Mm-hmm. The arguments against sodium restriction, you mentioned the Italian group that has published several data on this topic, showing maybe worse outcomes in patients that were sodium restricted. There's a editorial that you wrote in JACC Heart Failure, 2016, and another meta-analysis that came out last year, maybe pointing out to patients who were sodium restricted doing worse than those who were maybe on a more liberal sodium diet. Do you have a couple of words on those data as well?
Well, so I think the editorial in 2016 was from a trial that had enrolled, I think, around 900 patients, outpatients, and had looked at their reported sodium restriction. And again, the patients in that trial who had reported sodium restriction had not done as well as those who didn't report sodium restriction. So again, kind of contrary to our recommendations. Mm-hmm. I think one important aspect of that study, which we talked about in the editorial, was that the data weren't adjusted for calorie intake or other sort of nutritional aspects. And so again, this possibility of like reverse causality, like maybe people that are eating low sodium are not eating enough of other important things to kind of keep the mitochondria going and promote good general health. And so maybe that's why the sodium restricted patients didn't do quite as well. I think dietary patterns are challenging things to measure, and there's various techniques that have their limitations and advantages, but I think that we have to include other dietary aspects whenever we're thinking about sodium restriction in order to really understand the full effect of our recommendations.
Do you, in your patients, the heart failure patients, do you recommend a specific diet, maybe the DASH diet or a Mediterranean diet?
I think, again, you have to meet people where they are. For some of my patients, a Mediterranean diet would be so dramatic a change from what they're commonly eating. It might just be enough for them for that visit to say, try to incorporate a little more fruits and vegetables into your weekly intake. I think the DASH diet has some pretty good epidemiological evidence, both for preventing heart failure. And then again, you may be familiar with a study, Women's Heart Initiative, I believe, in which patients who reported adhering to the DASH diet pattern had better outcomes longer term if they had heart failure. But I think you have to be a little bit careful. There's a lot of potassium in the DASH diet, a lot of phosphorus. It depends on what your patient's kidney function is. Patients are often on potassium-sparing agents like spironolactone. So you have to adapt things a little bit depending on the clinical situation. Mediterranean diet, perhaps not quite as many studies looking at it, but certainly I think that's a great choice also. Those are probably the two most common patterns that I recommend. Yeah. But again, it really depends on the patient, I think.
Would you say, based on some of the data we covered, really some of the studies, again, use different cutoffs for what they call sodium restriction. Is there a sweet spot when you give them advice, they can stay between a certain range of sodium intake? Too low or too high is bad?
I ask people to try to adhere to 2,000 milligram a day restriction, knowing that'll honestly, based on our, as you pointed out, the national data and on our own measurements, that's probably going to be more like 3,000 milligrams a day is what they'll be able to get to. I talk about to patients about trying to do, I say the right thing, not in like a moral sense, but in the correct sense, doing the right thing 90% of the time, so that when you're going to a graduation party, you're going out to a special dinner, you can eat that salty meal and not get into trouble. If that makes sense. So, I think, again, eating good food is part of life, right? And you have to, I think anyway, allow people that pleasure from time to time, especially when their day-to-day life with heart failure is pretty challenging. So I think you just have to be realistic about your expectations.
Yeah. Does your approach differ between patients with preserved ejection fraction versus reduced ejection fraction?
Generally speaking, no. I direct a HFpEF program at Michigan, and so I see a lot of patients, and I do feel, and it's very anecdotal, but I do feel that those are the patients that more commonly tell me, I ate this or that meal and I gained 3 or 4 pounds, or I knew that I'd eaten too much salt the day before because this is the way I felt. And so this maybe stems back from this concept of salt sensitivity being an important issue or not. I'm not sure. That's part of what we're studying. But I do try to adapt recommendations based on what I see from the patient over time,
Yeah.
I had a patient he's an engineer and very, very exacting and specific about his sodium restriction. And then he got transplanted and continued to eat. It was something like 800 or 900 milligrams of sodium a day. And he was hypotensive and his kidneys were not happy and he was feeling terrible all the time. And it was just really a challenge to get that patient to kind of open up and kind of, relieve the restriction that he had been under. And so again, you just have to adapt to what the patient is giving you.
One thing that we read in a lot of these sodium restriction studies is the role for checking urine sodium levels in certain patients, especially post-diuretic use. Do you use it in your practice at all? So
I don't, because checking urinary sodium really depends on the timing of the last diuretic. So, and, knowing that you have clinic all day on a given day, you might be checking it an hour or 8 hours or 24 hours after the person's last diuretic dose. So it's tough. There's some nice data from Dr. Jeffrey Testani's group at Yale, and it's actually made its way into the European Society of Cardiology guidelines for heart failure, that checking a urinary spot sodium a couple hours after a dose of loop diuretics in the hospital actually has really good predictive efficacy for how well that dose is going to work. And so one of the AHRQ study that you mentioned briefly at the beginning, I'm working on with a pharmacist colleague, Mike Dorsch, who's the PI of the study. This was an app we developed to basically give people real-time information on the sodium content of their foods in grocery stores and suggestions at restaurants and things like that. But we had patients actually using chloride strips at home. Sodium chloride is salt, and there's some differences among patients, but sodium and chloride are pretty tightly correlated. And so we reasoned that people could use this test strip at home, at certain times after their diuretics to understand whether they're going to be effective or not. And so this is something we're going to start studying, in lieu of an urinary spot sodium. Does this chloride test strip give you a close enough look at what the sodium would be without sending it off to the lab and waiting a few hours? The idea being that having this estimate of urinary spot sodium might help guide inpatient diuretic use. Say when you're ready to send the patient home, is the dose you gave them this morning going to work? When they go home, maybe a patient is at home and they say, my Lasix is not working so well today. Having this sort of more physiological information for diuretic adjustment might be helpful. So that's something we're going to be studying over the next year or so. But in short answer to your question is no, I'm not using urinary spot sodiums much because it's hard to time them properly.
Yep. Like you mentioned, Dr. Testani's group has published data on low chloride levels, low serum chloride levels, and how those patients tend to be more diuretic resistant, maybe having worse survival overall. What would you like to comment maybe on this other aspect that is relatively new in the field of heart failure? We move beyond sodium and looking at chloride.
Yeah, I think it's fascinating. Like, wouldn't it be interesting if that was the important electrolyte that we should have been thinking about all this time? I don't know what to say about it other than that I think his work is really important, and I think may have pretty strong implications for diuretic use and dietary recommendations for these patients. I guess that's probably where I should leave my comments, because I think it's kind of early days, but it seems to be prognostically important and might have treatment implications down the road, I think.
Mm-hmm. And one last topic I wanted to touch base with you upon is something I haven't done in practice, but I've met heart failure physicians who've used hypertonic saline in patients with decompensated heart failure. When I first heard about it, I was a little confused. I was like, you're trying to restrict sodium in these patients, but on the other hand, you're giving them intravenous hypertonic saline to maybe improve diuresis, improve renal function. What would you say about hypertonic saline in these patients?
I mean, the largest studies that have been done are, again, that Italian group that had done the studies on fluid and sodium restriction, and kind of an underwritten about part of those studies, I guess, is the aspect that in most of those studies, people were randomized to hypertonic saline or not when they were in the hospital. And there's been some smaller studies subsequently. There's a meta-analysis of those studies done as well. And the meta-analysis suggested that you could lower mortality by using that intervention. And so it's definitely very intriguing. I feel like there would need to be a large study of just using hypertonic saline and keeping everybody's dietary and fluid advice the same to really understand what the true effects of that strategy are. But I mean, the data that are out there are pretty intriguing, I have to say. I feel like most of the patients I think about doing this in, their kidney function is already quite poor, or they're so extremely volume overloaded that I'm worried that even that small amount of volume might do harm. Yep. So I don't know if that makes me a chicken or what, but I think I've used it maybe once or twice, but maybe not as often as I should.
It's just very intriguing data, especially in some cases where you have diuretic resistance, I believe, where it may have a certain role. So as you mentioned, dietary studies are difficult to conduct because diet is really a part of your lifestyle. It's not just as simple as conducting a medication study where you take a pill or you don't, you take a medicine or you take placebo. What does the future landscape look like for dietary studies in heart failure?
Well, I mean, I'm biased here. This is what I do, and I hope we can continue to get our work supported. I think that key questions to answer are, as well as we can in general clinical practice, what should be the sodium threshold we recommend for stable outpatients? I think the sodium HF study I mentioned that's being conducted in Canada will go a long way towards answering that question. I do think it's important to do a large multi-center study of providing nutritional support to patients after hospital discharge. Probably you've heard of something called the post-hospital syndrome, where there's this several-week period where people are uniquely vulnerable after a hospital stay, particularly older people, and some of that may be malnutrition related. So I think that's really important, and obviously sodium restriction may be a part of that. I think there's a ton more we could do on just sort of the mechanistic understanding of how patients are affected by sodium, and indeed chloride perhaps might be an important part of that. Mm-hmm. But animal model data and studies in human hypertensives, a small pilot study that we did in HFpEF suggests that not everybody's physiological response is the same, and that some people it might be really, really important, and you might give a different recommendation to them. Someone who has vascular inflammation and oxidative stress and increased arterial stiffness with high sodium diet as compared to somebody else who has neurohormonal suppression and does much better. Like those would be physiologically different patients that you might give a different recommendation to. So I think some more mechanistic studies, carefully controlled diets with non-invasive cardiac and vascular measurements and biomarker measurements would be important.
Thank you. That was actually a great conversation. We really covered several topics, and sounds like there's a lot more to come in the future. Any parting advice or parting statements, any plugs you would like to make?
Yeah, well, first of all, I appreciate the interest in the topic and the opportunity to talk about it a little bit. I think, the main parting thought I would leave people with is just to have your listeners keep their minds open with the idea that maybe the sodium threshold for individual patients might differ, and to just really, again, bring home this point that low sodium diet is not the only aspect of diet that we should be thinking about in heart failure, and just really making sure that patients are maintaining their overall nutritional intake when you're recommending that they restrict their sodium, because oftentimes people are not able to do that without some specific instruction. So involve your dietitians when you can, and let an expert help you and help your patient.
That was great. Dr. Hummel, thank you so much for your time. And this episode will be out in the next week or two. I'll let you know.
Yeah, thanks again for the invitation. And I'm, again, glad you covered the topic. Thank you.
That brings us to the end of another episode that we had a great time creating. Thank you so much for listening. If you enjoyed our episode, don't forget to like, subscribe, and give us a high rating, as it helps other listeners find us. You can leave your suggestion for topics, critiques, things you think we can do better. You can email us at heartsuccessteam@gmail.com. You can actually find us on our website at www.heartsuccess.info. Our website now also provides links
to all the podcast providers where you can listen to this episode. You can find us on our Facebook page at Heart Success Team, or you can always reach me on Twitter at CardioBro.